Every physician will encounter patients with a variety of lumps, bumps, bruises, and masses. Sometimes these abnormalities are relatively simple lesions of the skin and subcutaneous tissues. However, any mass suspected in the musculoskeletal system needs to be identified early because the possibility of an underlying malignancy is ever present, albeit rare. Because we are studying the musculoskeletal system, this presentation will focus only on abnormalities of muscles, their investing fascia, or the bony tissues of the skeletal system. It will be necessary, however, to introduce other organ systems, specifically breast tissue and lymphatic tissue, to explain and teach safe, proper biopsy techniques. Part 2 of this presentation will return to common pathology of the musculoskeletal system. Welcome to this presentation of the lump mass scheme, Part 1. In this presentation, we'll discuss a simple case of a ruptured muscle and some commonly used biopsy and imaging techniques. Please read the slide comments and the attached transcripts. These two podcasts are not meant to be the small, convenient, short insight lectures presented to you earlier in the year. Rather, these podcasts, of which there are two, are meant to be full-length presentations that you'll be expected to listen to prior to coming to class. Doing so will make your assimilation of the material quicker and easier. While these two presentations are full-size lectures, they are not all-inclusive of all the biopsy techniques available to you, nor of the wide array of imaging techniques available. But it serves as a good introduction, and the special case of obtaining tissue samples from a head-neck malignancy is also discussed. There are no required readings for this presentation. However, you will be doing yourself a great favor if you read some of the recommended readings. I strongly suggest reading the 3 chapters on inguinal hernia, ventral hernia, and sarcoma. These 3 entities, especially inguinal and ventral hernias, are incredibly common in clinical practice. You'll see a variety of patient presentations of these pathologies of the musculoskeletal system, and besides, it'll make learning them in your GI course even easier. Sarcoma of the musculoskeletal system is relatively rare, but effective treatment depends on early diagnosis and staging performed via imagery or biopsy. Before we can delve into the various types of masses of the musculoskeletal system, either benign or malignant, I must first introduce you to the methods of obtaining biopsies. In addition, radiological imaging of the musculoskeletal system is mentioned to round out your understanding and ability to diagnose masses of the musculoskeletal system. In this presentation, I will expect you to appreciate abnormalities, either palpable, non-palpable, visible, or occult, of the musculoskeletal system based on taking a complete history, performing a physical exam, and interpreting radiological imaging. I also expect you to, of course within the confines of being a first-year medical student, to select appropriate diagnostic imaging in helping evaluate various causes of malignant and benign lumps or masses of the musculoskeletal system. It's important you understand the variety of causes of lumps or masses of the musculoskeletal system your patient may present with: congenital, traumatic, infectious, acquired, or neoplastic. And any can affect the musculoskeletal system, either smooth muscle, skeletal muscle, or bone tissues. You'll be expected again within the confines of your education as a first-year student to formulate and discuss various treatment options for these maladies of the musculoskeletal system presenting as a lump or mass. In addition, there is probably no more common presentation of the musculoskeletal system than a hernia. What is a hernia? What is fascia? How are the two related? Discuss how a hernia can present as a lump or mass or neither. If hernias present as neither, how can they present? In addition to understanding relationships between fascia and muscle tissue, you'll be expected to describe various kinds and types of hernias and how they may appear on physical exam or radiographs. In addition, as part of your ability to establish a diagnosis, you'll be expected to define biopsy and give examples of several types of biopsies. Also discuss why breast tissue, while it's not part of the musculoskeletal system, is an ideal tissue to discuss imaging and biopsy techniques. Describe the difference between an incisional and excisional biopsy. What is panendoscopy and when should it absolutely be performed before the biopsy of a lymph node? What is a Virchow's node? Who is Virchow? What is the most common cause of a Virchow's node in a woman, in a man? What was previously believed to be the most common cause of a Virchow's node years ago? You should discuss the various risks, benefits, and common complications and indications for the various forms of tissue sampling techniques. In addition, differentiate between culture, cytology specimens, histology, and open excisional biopsy specimens. And if that weren't enough, relate the embryology of the musculoskeletal system to the anatomy of the various lumps or masses which occur in mesenchymal tissue derivatives. Remember, we're only going to discuss and consider lumps and masses of the musculoskeletal system, hence the photo here of Arnold. And while I discuss how breast tissue is an excellent teaching medium to learn biopsy techniques and the special case of head and neck biopsies, other lumps or masses of the body, subcutaneous tissues, or skin will be discussed in their respective organ or system-based courses and not as part of the musculoskeletal system. For example, melanoma will be discussed in your dermatology course. HIV-related masses of the skin, such as Kaposi's sarcoma, which is not a true mesenchyme-related sarcoma, will be discussed as part of infectious disease studies. Or primary tumors of the lymphatic or immune system, such as lymphoma or leukemia, will be discussed in your hematology course next year. The clinical scheme guides us to a potential diagnosis based on the anatomical location of the lump or the mass. The original scheme used years ago was incomplete as it didn't allow for acquired lumps or masses of the musculoskeletal system, and hence that original scheme has been revised. You're going to see the revised scheme here. An example of an acquired lump or mass found on physical exam is a hernia, a fascial defect, or perhaps a ruptured or torn biceps muscle or an Achilles tendon. In order to accurately and safely diagnose a lump or mass of the musculoskeletal system, we must first determine whether we can see or feel the lump or mass, and if not, what do we do with an occult lump or mass found incidentally in an imaging study? The best example of an occult lump or mass? An adrenal tumor called an incidentaloma. Yes, that's what it's actually called, but we're going to save that for your endocrine course. The scheme is broken down into anatomical regions of the body because, as it turns out, where a lump or mass is located on the body has as much to do with whether it's likely benign or a malignant process as does a lump or mass which is found only on a radiological imaging study. If you review the scheme, you'll notice incidental, non-visible, or non-palpable findings, once they've been imaged and become visible, are treated as palpable or visible. This is the way we think of such objects clinically. Simply, it depends on where it's at in the body, how large it is, what organ system it belongs to, and whether the patient is symptomatic. As mentioned, the scheme offers us two ways to begin the investigation of a patient who presents to our office with a visible lump or mass. First and foremost, we must ascertain whether the mass is palpable or visible or hidden, occult, and then determine whether the patient has symptoms or no symptoms. This, of course, begs the question, why or how would or could a patient show up in our office with a lump or mass they can't see, feel, or have no apparent symptoms from? The answer is easy. Just because we can't see the region in question with our eyes doesn't mean we can't see it or haven't seen it using radiological imagery. You'll soon understand many patients can present to your office with an occult mass found incidentally on a radiograph, which was ordered or requested to work up an unrelated problem. Again, the best example is a small asymptomatic tumor of the adrenal gland called the adrenal incidentaloma. Hence, a patient can present to a surgeon's office with nothing more than an abnormal radiograph or CAT scan in hand. We treat such lumps or masses now as visible as the scheme tells us what to do next. Here's an example not related to the musculoskeletal system, but it allows us to understand how a patient can present with either an obvious lump or mass or simultaneously an occult lump or mass. Breast cancer can present as small microcalcifications, which can't be seen or felt unless they are imaged with a mammogram. In addition, lymph nodes, which may be non-palpable, reveal themselves in a mammogram, and in addition, a mass within the breast may or may not be palpable yet, can also be visible on the mammogram. Because breast tissue is easily accessible, it serves as a good example of how malignant processes can present as an occult mass, and in turn, breast tissue allows us to readily teach and demonstrate the variety of imaging and biopsy techniques used to diagnose similar abnormalities found in muscle or bone tissue. In this mammogram, we can see the mass in the lower aspect of the breast, macrocalcifications in the upper medial aspect of the breast, almost always benign. Microcalcifications, however, can be an indicator of an underlying cancer, and we can see lymph nodes in the patient's axilla. In addition, pectoral muscle tissue is imaged. Your first diagnostic mammogram has just been read for you, and the abnormalities are identified here. Let's begin with a relatively simple example. Our patient presents with a visible and palpable mass over the anterior lateral aspect of his right arm. We have time to perform first a complete history and physical exam. Let's see where that takes us. First, we need to gather some information on this patient's abnormality. What would we like to know, among other things? How long the mass has been there? Does it hurt? Is it associated with any numbness or tingling around the skin or in the hands or fingers? Does the patient remember any traumatic event? Is the mass associated with any obvious fever, nausea, redness, erythema, pus? Does the patient only have one such abnormality, or are there others? Perhaps the most important part of obtaining the history and physical exam process is to obtain and read the patient's old medical records, including radiographs. Don't just read the reports, look at the actual films, or today, the DVDs. You don't want to repeat unnecessary testing or questioning if the records indicate a prior workup, blood test, radiographs, or biopsies have already been performed. A review of the patient's old medical records is invaluable. Legibility and availability are the two biggest problems. Get in the habit of sending your records to any doctor you're referring the patient to. It takes time, but it's well worth it, and the referring physician will greatly appreciate it. If you've ever been to a physician's waiting room, one of the first items you'll become immediately familiar with is the physician's health history form. On this slide, I show you the forms I used in my office as a surgeon to help me rapidly obtain a relevant review of systems. When you enter practice, you'll create your own version of such a form. It's only a guide, and it usually highlights the need for further questioning. You can click on the link to order your own forms. In addition to obtaining a thorough review of systems using such a form, you'll need to perform a complete history and physical examination, regardless of whether the patient's already had an examination by another physician. Many tumors of the musculoskeletal system will present with obvious lesions of the arms and legs, and in some cases, associated adenopathy, or enlargement of lymph nodes. With our patient, we can see the mass and palpate it, but we still don't seem to have enough information to determine if it's involving the skin, the subcutaneous tissues, fat, muscle, bone, or is it an enlarged lymph node? What should be done at this point if our history and physical exam, the review of systems, and our own intuition isn't enough? What if we've never seen such a giant lymph node on the upper arm? Should you discount it as a possibility because you've never seen it before? Well, imaging may be indicated based on the information gathered from the patient's review of systems, the history of present illness, and the physical exam. With skill, practice, and experience, you will inherently learn which techniques are the best for imaging the various systems of the body. This patient has an abnormality of the right upper extremity and would probably be best served initially, that is if our physical exam is non-diagnostic, with an ultrasound. You could choose a plain X-ray if you suspected an old healed fracture. You could choose a CT scan if you think it might be a giant lymph node, or an MRI if you think it's a muscle tumor called a sarcoma, or any other imaging test. However, the best initial choice, at least in this case, is probably an ultrasound if we're not familiar with the clinical presentation of this patient. An ultrasound is relatively inexpensive, it's easy to obtain, it's non-invasive, and it can be performed in a physician's office if they have the ultrasound machine available. Many times, the physician's ultrasound is connected to the adjoining hospital's PAC system, PAC. It allows us to upload our images directly to the hospital system so the radiologist can interpret it. An ultrasound of the arm mass will tell us if the lump or mass is confined within the subcutaneous tissue, has the characteristics of a lipoma, which is a small benign ball of fat, whether it's vascular or encapsulated. Encapsulation is a sign of a benign process. Cancers are usually not encapsulated because they have a tendency to invade everything close to it. An ultrasound can also tell us if it's solid or cystic. Most imaging of the musculoskeletal system, especially and particularly the muscular system, is best addressed with an MRI scan. An MRI scan shows good definition of the musculoskeletal tissue because, as you remember, MRI scans are based on water content and proton spin. Please note, this doesn't mean a plain X-ray, a CAT scan, or ultrasound shouldn't be considered. As I mentioned, in time you will learn which imaging techniques will give you the best information for the least cost and the least inconvenience to the patient. If we've already obtained imaging and we still don't have a clear diagnosis, our intuition doesn't lead us to a diagnosis, and the patient's history, review of systems, and physical exam leads us astray, we might consider obtaining different types of imaging or even a biopsy. The image here demonstrates what goes through the patient's mind when you suggest biopsy. Most patients believe it's a painful, difficult, expensive, and bloody technique. Thankfully, a biopsy done in skilled hands is usually none of these. Let's look at how we can obtain a biopsy and discover some of the various techniques used. What is a biopsy? A biopsy means removing a piece of tissue from a specimen to evaluate via its histology under a microscope or via bacterial growth in a petri dish the cellular structure, thus aiding in the diagnosis of disease. Note, a biopsy can be performed on living or dead tissue. Microbiological cultures can be obtained at the same time as a biopsy. Depending on your clinical acumen, you may need to obtain bacterial or viral cultures or even specialized cultures, for example, for tuberculosis or anaerobic bacteria. The pathologist will then help you decide if further testing, a larger biopsy specimen, or operative removal is required of the mass or lump in question. In addition to performing a tissue sample or a microbiological culture, it may be necessary to remove fluid, aspirate, centrifuge, and then study the collected cells under a microscope. An example of obtaining such a sample for microbiological culturing and or cytological microscopy is a pap smear. Cytology specimens are commonly obtained from the pleural cavities also. Fluid from the chest cavity is removed, centrifuged, cultured, and or viewed under a microscope to look for malignant lung cancer, or to assess a sputum sample for malignant cells, or a bone marrow aspiration to look for evidence of leukemia or other immunological diseases. A pap smear is obtained from cells of the cervix. Small biopsies of tissue from a lymph node can also ascertain the presence of benign lymphatic tissue or cancerous lymphatic tissue called a lymphoma. I have placed several links here that when you click on them will take you to various videos demonstrating how cytology samples are created, fixed, or interpreted. I haven't forgotten our patient presented with a mass of the right upper arm. However, the scheme dictates, based on the anatomic region, what the workup would consist of. If our physical exam had shown our patient to have evidence of enlarged lymph nodes in the axilla or even the supraclavicular region, we may entertain the possibility of infection or worse, a cancer, a malignancy. Some patients present with an enlarged lymph node in the supraclavicular region, which is often indicative of an underlying malignancy of the head and neck tissues. For example, cancer of the tongue, pharynx, tonsils, etc. Patients who smoke or chew tobacco or drink alcohol often present with malignancies of the head and neck region. The workup of an enlarged lymph node is rarely, if ever, an open biopsy first. If an enlarged lymph nodes, as shown in these photographs, is limited to the left supraclavicular region, known specifically as a Virchow's node, we must be suspicious for a malignancy either of the breast in women or of the oral pharynx or nasopharynx in a man or a woman. The left supraclavicular node can also be consistent with lung cancer or a gastrointestinal malignancy. This slide is packed with information. I've placed a link to an image from the New England Journal of Medicine showing a Virchow's node and an explanation of how these nodes are assessed. In addition, because there's often so much confusion about the cause of a Virchow's node, i.e. whether or not they're from the gastrointestinal malignancies such as a stomach cancer or from breast or lung tissue, I placed a link to a discussion where the interviewer and interviewee, both from the American College of Surgeons, discuss the most common cause of a Virchow's node today being breast cancer in a woman and lung cancer in a man. Most of us and most practicing physicians today were taught a Virchow's node is most commonly associated with gastrointestinal malignancies. The data today, however, reveals a Virchow's node is more commonly seen in breast cancer in women and lung cancer in men, probably because breast and lung cancers are more commonly seen today than are gastric malignancies. Regardless of the cause, if your mass of the musculoskeletal system is associated with lymphadenopathy, you must remain open to the possibility of a malignancy distant to the enlarged lymph nodes, and your patient may require a more detailed physical exam or directed detailed radiological imaging to look for the primary source of the cancer. Lumps, which we determined to be enlarged lymph nodes, would of course rarely be a primary concern to the musculoskeletal system unless an underlying malignancy or infection from the muscle or the bone has affected the associated lymphatics. Because we've spoken about Virchow's node, you must understand a difference between superficial lymphatic drainage anterior to the sternocleidomastoid muscle and deep lymphatic drainage involving tissues around or in the carotid sheath, which contains the carotid artery, the internal jugular vein, and the vagus nerve. Palpable lymph nodes in the posterior triangle of the neck or the occipital lymph nodes is almost pathognomonic for infectious mononucleosis, the kissing disease. It's rare for cancers to spread to the posterior chain of lymph nodes near the occiput. Palpable lymphatic nodes of the head and neck, especially of the deep lymphatics, is often associated with cancers of the head and neck. Such cancers can present as soft tissue tumors of smooth muscle, i.e. the esophagus, or skeletal muscle, such as the pharynx. A Virchow's node in the left supraclavicular region was often classically taught, as is shown here in this slide from the TEMA Atlas of Anatomy, to be secondary to gastric cancer, which is spread to these supraclavicular nodes via the thoracic duct. Today, however, in a woman, a Virchow's node is most likely secondary to a breast cancer. If you're interested in learning who Virchow was and other processes holding his name, I provided a link so you can learn more about this famous pathologist. However, back to our patient with a palpable and visible mass of the upper arm. Is this a giant lymph node? Is this muscle tissue? Is it ruptured muscle? Is it a torn, bunched up tendon? Is this an organized blood clot called a hematoma? What would be an appropriate biopsy for this area if we were unsure? And perhaps more important, is a biopsy actually necessary if an imaging study, say ultrasound, was non-diagnostic? One biopsy technique called a brush biopsy is shown here. The brush biopsy technique allows superficial cells to be removed, fixed to a slide, and viewed microscopically, or sent to the pathology lab for special staining or genetic studies. Our patient with a head and neck mass, or lump, or a Virchow's node would perhaps benefit from a brush biopsy kit. However, our patient with a mass in the upper arm would not benefit from such a biopsy technique. Sometimes we can obtain a biopsy of skin tissue by performing a punch biopsy. A punch biopsy is almost identical to a leather punched used by artists and craftsmen who make belts or purses made from leather. Punch biopsies are commonly used by dermatologists in obtaining a sample of skin or a piece of a suspected skin cancer. If the entire skin lesion is removed in total, it's known as an excisional biopsy. If only a small piece of the skin cancer is removed with a small rim of normal tissue and the skin lesion is not removed in total, it's known as an incisional biopsy. The punch biopsy kits used in a physician's office are often made of plastic, they're sterile, and also disposable. I've provided a link of an excisional biopsy being performed on a non-cancerous lesion. This will help you understand how and why a punch biopsy is performed. I've also included a video clip showing how an excisional biopsy is performed. Understand the difference between an excisional and an incisional biopsy.
In this case, we're using the soft tissue tip on the straight sleeve. We're using it to remove an irritated squamous papilloma from the left side of the tongue. As you see, we're using air only, no soft tissue pickup forceps. We will go from side to side during the release process. As we cut through the abnormal tissue into the normal tissue, you can actually feel a difference with the laser as you cut through. As vascular as the tongue might be, you see that hemostasis is not a problem in this case. We take our time and release from side to side until we have completely excised the lesion. This patient did have aid. This smooths the tissue and helps to control the bleeding. As you see, we're working non-contact. The patient is released and that it was an irritated squamous papilloma from the left side of the tongue.
Once we've determined our patient requires a biopsy and we understand the various types of biopsies that can be performed, it's now important to mention the special case where an open, incisional, or excisional lymph node biopsy should never, or at least rarely never, be done first. Malignancies suspected of the head and neck region with or without associated palpable lymph nodes should never have an open, incisional, or excisional biopsy performed without including first, as part of the workup, performing procedures included in a panendoscopy. Panendoscopy refers to performing a complete endoscopic examination of the head, neck, nasal cavities, larynx, and pharynx, and the upper GI system. Performing an open incisional or an excisional biopsy of a lymph node in the head and neck region can result in seeding or spreading the cancer. If the lymph node is already necrotic, it's possible such a biopsy site would never heal. In these instances, an enlarged lymph node of the head and neck region would first be subjected to a fine needle aspiration. A hollow 22-gauge needle is attached to a syringe, the lymph node is stuck, and cells are aspirated from the lymph node and sent for pathological analysis. Occasionally, a physician will be forced to work up a patient who has an unknown malignancy in a lymph node, but the primary source of the tumor is not known. This is called a tumor of unknown primary, and they're relatively rare. In this case, nasopharyngeal carcinoma must also be excluded. Panendoscopy will need to be performed, and even blind random biopsies done of the nasopharynx to exclude this tissue region from harboring a tumor. The take-home message is, if you suspect a patient has a head and neck tumor, you should perform panendoscopy. If that patient has an associated enlarged lymph node, perform an FNA and not an excisional or incisional biopsy, because you could seed and spread the cancer. Ultrasonography is complementary to other imaging techniques. It can help determine whether an underlying questionable mass or lump is solid or cystic, i.e. fluid-filled, whether it has signs of cancer such as an irregular shape or invasion, and it can assess the size, depth, vascularity, and as mentioned, invasion of the lesion into deeper tissues. It's relatively inexpensive, convenient, easily available, usually painless, and the results are often reproducible. It gives us lots of information. Ultrasonography is helpful in obtaining an FNA, or a biopsy of tissue. In the images here, we see how fine needle aspiration, using ultrasound guidance, is used to assess a nodule of the thyroid gland, a nodule of a woman's left breast, and an apparently necrotic left-sided neck mass. It is fine needle aspiration or fine needle biopsy that can be performed within lymph nodes of the head and neck or other regions safely to help the pathologist determine where the primary tumor is located. Risk of seeding is infinitesimally small with FNA. As mentioned, cancer of an unknown primary, while unusual, dictates the physician understand open biopsies of enlarged or palpable lymph nodes is contraindicated. Please click on the icon to review an article regarding the workup of cancer of an unknown primary. I've also placed 2 links showing nasal endoscopy and a biopsy of a nasopharyngeal carcinoma. It's indeed rare that an individual with a cancer of an unknown primary would have nasopharyngeal carcinoma, but it must be considered, and it may dictate the manner in which a patient is properly worked up to avoid spreading cancer cells while searching for the correct pathological diagnosis. In addition to performing an FNA, the physician can also obtain a core needle biopsy or a tru-cut biopsy. Under ultrasound or CT guidance, a larger biopsy needle can be used to take a tissue sample from a suspecting or suspicious mass or lump, be it in the musculoskeletal system, the integumentary system, or an organ system. This procedure must be performed using sterile technique, and if a mass is palpable, it can be performed without any radiological guidance at all. Because the biopsy specimen obtained is larger than that obtained via an FNA, the physician must be aware of any adjacent blood vessels, potentially causing unsuspected bleeding. Despite the image here, I'm not endorsing BARD, but I would like you to click on the link provided to view a core needle biopsy of a suspected breast nodule. Here's a 6-minute video demonstrating an ultrasound-guided core biopsy of breast tissue. Again, note that while breast is not considered part of the musculoskeletal system, it is a good source to demonstrate and learn FNA, core biopsy, incisional or excisional biopsy techniques on. Next year, as part of the GU system, a separate presentation is given specific for breast biopsy techniques. Complications of biopsies include, but are not limited to, bleeding, infection, pain, bruising, hematoma formation, damage to adjacent structures such as nerves, arteries, or lymphatics, wound dehiscence, and poor wound healing, especially after open incisional or excisional biopsies, and even poor cosmesis and poor scarring, even the possibility of an allergic anesthetic reaction with loss of an airway, and of course rarely even death. But now, finally, back to our patient who presented with a mass in the upper arm, and our physical exam was not entirely diagnostic. Our clinical acumen didn't lead us to an automatic instant diagnosis. Should we image, biopsy, Both, neither, wait and reassess or refer to a more experienced clinician. The scheme suggests that we're dealing with either a superficial or deep tissue of an extremity, and the physical exam suggests it most likely was an acquired lesion. Our history reveals the patient experienced an acute, painful injury while at the airport lifting his suitcase. With this information, we can do more. Currently, the patient's asymptomatic, but initially the injury was associated with some bruising, and our physical exam shows he's still able to flex his forearm, but with some discomfort and difficulty. The diagnosis is a ruptured biceps tendon or ruptured biceps muscle. We could have imaged with ultrasound or MRI scanning, but this expense would have probably been unnecessary. We could have also biopsied the lesion under ultrasound guidance, but that too most likely would have been unnecessary. The treatment for this condition in an elderly patient is rest, an arm sling, and defer surgical treatment. Rarely in an elderly patient is surgery indicated. If, however, our patient had been younger, he most likely would have been a candidate for a tendon repair or repair of the muscle belly by an orthopedic surgeon. This image shows how the tendon, once identified, see image B, in the subcutaneous tissues is then reattached distally. See the arrows in image D. The complete repair is described in the referenced article. You may click on the link if you so desire. While this case was relatively simple, what if we had been unable to see or feel the mass, but it's seen on CAT scan or MRI as an incidental finding? Further, what if we are unclear if it's in the skin, the fat, muscle, bone, or was it a lymph node? The scheme dictates in such an instance this would be defined as an occult mass and is only visible on radiographic studies. Once it's been visualized, we need to know whether the patient has symptoms. If the patient has symptoms, we must determine if the symptoms are related to the occult mass. For example, does the patient have associated blood in their urine, blood in their sputum, pain on movement, associated fevers? Should we obtain blood or urine or sputum testing? If so, should we do this first or order additional imaging studies first, or both? What does the patient's history and physical exam guide us to do? Thus, according to our scheme, we have an occult incidental finding seen only on radiographic studies, but the patient is symptomatic. Given this patient is symptomatic, we're now guided to do a further workup depending on what the patient's symptoms are. If the patient is asymptomatic, we may need to perform further radiological imaging or blood testing, but remember, once an occult incidental finding is found, whether it's palpable or non-visible externally, it would be considered now as visible, and its workup would depend on which region of the body it's found in. We've already learned abnormal masses of the head and neck region are approached differently in our biopsy decision-making than an obvious lesion of, say, the abdomen or chest. In our next presentation, part 2 of the lump mass scheme introduction, I'll present several cases specific to the musculoskeletal system and discuss how they can be worked up and a definitive diagnosis made. It's impossible in these 2 lectures to describe all of the imaging biopsy techniques available in working up the musculoskeletal system. However, you'll get a good introduction to some of the more common abnormalities. Following this copyright slide, there's a 9-question quiz to reinforce some of the salient topics introduced in this presentation. I'll see you again in part 2, where we'll look at a series of cases that are indeed specific to the musculoskeletal system.